and welcome to day 2 of our Gambling Summit. My name is Kelly Gage, and I am the Program Manager for the Illinois Department of Human Services, Division of Substance Use Prevention and Recovery Gambling Disorder Program. On behalf of Governor J.B. Pritzker, Secretary Grace Ho, Super Director Laura Garcia, Deputy Director Stephanie Frank, and Gambling Administrator Jim Wilkerson, and myself, I'd like to welcome you again to day 2. Before I introduce our keynote speaker for this morning's session, I would also like to just share with those of you who may not know that the Department of Human Services, Super, we offer a 30-hour gambling disorder clinical training, which is offered each year, several times a year, and right now virtually. The last one that we are scheduled for will happen in May, but I believe we may be full. So what we visit, the WeKnowTheFeeling.org website, where you will see announcements of upcoming trainings as well as webinars. We'd also like to inform you that the state of Illinois DHS offers clinical consultation or supervision twice a month with Jody Bechtold, who some of you may have heard yesterday. And that training is actually for gambling supervision. It's not a training, it's supervision. If you are looking for a gambling supervision group that you'd like to take part in, you can please drop your information, your name and your email in the chat box with supervision. We will be sure to share more details with you. So, and now without further ado, it is with great honor that I introduce our keynote speaker for this morning, who has been involved with Illinois for quite some time with the gambling program, Dr. Lori Rugo. Dr. Rugo brings 38 years of experience in the field of problem and responsible gambling, including treatment, prevention, research, and responsible gambling to her work. She has managed problem gambling programs within the Veterans Administration and the private sector and within state systems. She's also participated in research on brief screening for gambling problems, as well as a broad range of other problem gambling related research projects. Dr. Rugo is an assistant professor in the Department of Psychiatry at the University of Maryland and special projects consultant with the Maryland Center of Excellence on Problem Gambling. We are excited to have her with us this morning. You're in for a treat. What we would ask you to do, if you have any question and answer box, and we'll answer those at the end of the session. Thank you and enjoy the rest of the session.
Great, thank you so much, Kelly. And let me just share my screen here and pull up my slides. And it is so great to be here. I was trying to figure out when I first came with Joanna Franklin, one of the first trainings we did on the 30 hours. And I think it was right after one of the first brief screens was published, and that was published in 1997. So shortly after that I did my first training in Illinois, and bless all those people who sat through that. And I'll talk a bit more about that experience later, because it really ties into this screening. It was the first time we really encouraged people to use brief screens, 2 questions. Anybody can put that into their intake packet. And I'll talk a bit about the results of that in Illinois. So thank you all for being here. This clearly for many, many years has been a topic near and dear to my heart. And just wanted to provide some acknowledgments. Dr. Seth Eisenberg from Illinois was really a pioneer in beginning the process and shared ideas in terms of developing a gambling GBIRT. And I wanted to acknowledge the team from the Maryland Center of Excellence on Problem Gambling that's collaborated around a lot of the research we've done on screening and developing an SBIRT, an evidence-based SBIRT format. So I stand on the shoulders of many dedicated people. So we'll look at understanding the SBIRT model, how to sell it. Why should we even bother with this? That's a big part of getting buy-in from organizations and states and agencies into why we should do this, why we should use this model for gambling disorder, and look at some of the relevant research and just the process of what do you do? How do you do this thing? How is it the same or different than a substance use SBIRT, screening and brief intervention and referral to treatment? So first, the sell. And trust me, I have talked to a lot of state directors, agency executive directors, and just saying, gee, it's really the right thing to do doesn't always work. So we really need to back up our statements. And we've got now a good bit of research on the fact that individuals with substance use and mental health disorders are at significantly higher risk to also have a gambling problem. But they're at risk to have gambling impact their recovery from their substance use and mental health disorders as well. So it's not just about finding people who have a gambling disorder, but broadening the conversation into what's the impact of gambling on what you're here for in the first place. We know that the rates of problem gambling among those in treatment for substance use disorders range from 7%, and the rate in the general population for gambling disorder is about 1%, 2% at the most. So 7%, even at the low end, is quite a jump from the general population numbers, up to 40% and even higher in medication-assisted treatment programs. The research has consistently shown the highest rates in those programs, and we really haven't dug into why that might be exactly. Gambling may become a sequential addiction for individuals recovering from substance use disorders, and that is such a common pattern. In a supervision session I had yesterday, it came up again, a case where somebody had 15 years in recovery from their substance use disorder, and suddenly they're facing a devastating gambling problem and didn't see it coming. So that sequential addiction factor, and gambling can be a relapse risk factor, even if it does not reach problematic levels in and of itself. So multiple reasons. And we know that problem gambling is at least 2 to 5 times more prevalent among those with mental health disorders and in the general population. And that just isn't those with anxiety and depression that you might think about, but those with serious and chronic mental illnesses like schizophrenia and schizoaffective disorder. One study of community mental health and VA centers found that with folks with that mental health diagnosis, problematic gambling was about 19% of that population, and it carried with it more legal problems, higher rates of depression, more use of treatment services, so a lot of complicating factors as you might expect. Gambling and problem gambling, and nobody asks. We'll see that later. It can exacerbate psychiatric symptoms. It can precipitate a psychiatric crisis, hearing the voices telling to do harm to oneself, increased rates of depression, increased rates of anxiety. And so many of my clients, their physicians kept increasing the medications to deal with those exacerbated symptoms and never asked about gambling as a contributory factor. And the high suicide rate. 17% of those in treatment for a gambling disorder have made a significant suicide attempt, as reported in the DSM-5. So very significant issues if this goes unrecognized and unaddressed. Gambling has been found even at moderate rates to adversely affect treatment outcome. Increased likelihood of dropping out early from treatment, use of more expensive treatment options like inpatient psychiatry and inpatient detox services, increased positive urine toxicology screens, more legal problems. The whole range of things are correlated with co-occurring gambling problems. So it's not just mental health and substance use, it's also healthcare settings. And we now have research that shows 10 to 25% of individuals in general healthcare settings can be identified as at risk or problem gamblers. And even that at-risk status has been associated with increased rates of medical problems like high blood pressure, cardiovascular problems, gastrointestinal problems, obesity, sleep disturbance, chronic pain, more accidents and injuries, greater use of emergency room services. So you see, it's not necessarily causal, but we can, speculate it may be the stress of the problematic gambling adding to these problems. It may be the lack of attention to healthcare. It may be a whole range of factors. Another study, really cool study out of Iowa by Don Black, just looked at gambling disorder with a range of poor health habits, more sedentary activities such as watching TV more hours per day, a poor diet, more caffeine intake, poor dental care. When you think about it, if I have a gambling disorder, I'm not going to take my gambling money and spend it on preventive dentistry or medicine. I'm going to win, and then I'm going to buy the clinics. They found that people with gambling problems were more likely to put off medical appointments because of financial concerns. I either don't have the money. I had one client who was in his 80s who fired his doctor, and it came down to the fact that he didn't want to pay any money for the medicine he was taking. And they rated their health as much poorer. So a lot of connections to just overall health care as well as well-being. So we have substance use populations, mental health populations, primary care populations, college and young adults. Young adults, college-age kids have the highest rates of problem gambling consistently than any other age group. 60 to 70% of young adults, college students have gambled in the past year. Among college students, 5 to 14% meet criteria for problem gambling. It's related to substance use, problematic substance use. College athletes in research have been found to be particularly at risk. The competitiveness may lead to competitiveness in terms of gambling issues. In one study, twice as many students who had gambling problems considered suicide as those without. So suicidality in this age group as well connected with gambling. Okay, college students, mental health, substance use, primary care, child protective services, and domestic violence services. We used to think it wasn't an issue among folks with gambling problems. We were proven wrong by the research. In one study of emergency room admissions that were a result of domestic or intimate partner violence, it was 10 times as likely if the partner had a gambling problem. If you combine the gambling and the substance use, the violence was 50 times as likely. And that's been reported in other studies as well. In other studies where they looked at was somebody the victim or a perpetrator of violence, the rates are nearly equal for the person who has a gambling problem or the partner. Both are likely to become violent or to be the victims. And, when money is involved and you try to get between somebody with a gambling disorder and their money, very volatile situations. Or if you decide I'm going to come honest about where the money isn't, and you tell your partner that there's no money left, that the mortgage or the rent hasn't been paid, a very volatile situation. And we can't forget the children. Children living in a home where gambling is a problem are 2 to 3 times more likely than their peers to experience parental abuse. And again, it's not just the gambler who may be abusive, but the stressed out partner who may be abusive. And the questions are asked about substances, about alcohol or drugs, but not usually about purchasing lottery tickets. That can be very problematic. So we need to screen in these situations as well. So a whole range of places where we might want to implement some sort of expert or screening, effective screening process to assess the impact of gambling on what's bringing people to those services. And there are significant barriers that we need to overcome for folks with gambling issues seeking treatment. In 2015, the Association of Problem Gambling Services Administrators and the National Council on Problem Gambling did a national study. And since no money comes from the federal government, this is the only study of its kind looking at the scope of problem gambling and services throughout the country. Now, when we compared in 2015, about 11% over the age of 12, 23 million who needed substance use disorder treatment received it. So those who needed it, 11% for substance use received treatment services. In the following year, when our study was connected, 1/4% of the people who needed gambling disorder treatment received services at a publicly funded specialty facility. That is a huge difference. We have so much catching up to do in terms of the lack of awareness that professional services are available and how to access them, how to overcome an avoidance of seeing how serious this problem is. Because if I realize that I need to give it up or cut back, I don't have any hope of fixing the problem. For a gambling disorder, the hope of continuing to gamble and win so I can wipe out all my problems is a huge barrier to people seeking services. Cultural barriers and lack of multicultural low-cost services. And there's so much more shame, and we see this in the research over and over. Shame and stigma, reduced self-esteem associated with gambling problems, even more so than other addictive and mental health issues. According to a very large national comorbidity survey replication that looked at substance use as well as gambling and mental health issues, individuals who had a lifetime history of a gambling disorder, half of them received treatment for some other mental health or substance use disorder, but absolutely none, zero, not one, in that very large national survey received any treatment for gambling problems. So half of these folks are already getting services in our systems, and none of those who are getting other services are getting any help for their gambling. We need ongoing education, promotion of health, and awareness activities to bring light to this disorder and to create the services like a gambling expert that are necessary. So now this may be redundant, and many of you may have experience with expert, and feel free to type in the chat, yes, if you've had experience with expert for substance use disorders. So it's screening, and we need a brief, simple test to determine if a client is at risk or may have a gambling disorder. Then we need a brief intervention. How do we explain these results? How do we provide some information on how to gamble more safely, or assess readiness to change or readiness to seek help for their gambling problem. And then we need a place to refer these folks. We need folks who are doing treatment competently and effectively for gambling disorder. And we need a range of interventions for those at various levels of risk. And it's important to remember that a positive screen doesn't constitute a diagnosis. It just suggests the at-risk status or the probability that there may be some impact of gambling on this person's well-being, recovery, or overall health. So the goals for a gambling expert are not merely to find a case of gambling disorder. That may be down the list. We want to open up a conversation about the role, potential risks, and impact of gambling on a person's health, recovery, and overall well-being, a much bigger umbrella conversation than just making a diagnosis. We want to create curiosity in the folks we're working with. Oh, what is the role of gambling? Never thought of that. Pre-contemplative. Nobody's talked to me about this before. And we want to give clients permission to talk about gambling without fear of being given another label or handed another problem. We don't want to shut down the conversation. So if somebody, is positive, we have to inhibit our pouncing reflexes as clinicians and just keep the conversation going and begin to make connections between any gambling activities and behaviors with things that our clients may be more concerned about: their mental health, their substance use, their high blood pressure, their family conflicts, whatever their concerns are, and we just begin connecting the dots. Individuals, and finally, we look at identifying individuals who may be at high risk or are in the process of having or developing a gambling problem, and assist individuals to reduce or eliminate harmful aspects of their gambling behaviors, which may mean stopping gambling, or which may mean reducing or controlling or setting limits or protections around gambling behaviors. Enhance motivation for individuals for whom it is appropriate to accept information or referral to other specialty services. So a whole range of goals in terms of why we're bothering to do this. So let's get a bit more specific, choosing a screening tool. So as I mentioned earlier, back in 1997, the first very brief screen, a 2-item screen, the LIBET that we'll look at, was first published, that, there was some evidence that this could be an effective tool. And we want to stick to 2 to 4 questions before the LIBET. The shortest screen was the South Oaks gambling screen, which is lovely for other purposes still, but not usually, short enough to put into an intake screening. The 4 screens have been identified as working about equally well out of some research we did in Maryland. So in looking at how these work in research studies, there's really not all that much difference in terms of their specificity and reliability. So you may want to choose based on other issues in terms of the language that are used, the number of questions you want, things like that. So here is the LIBET. And if you know much about gambling disorder, you're going to recognize that the items included in these are very consistent with diagnostic level criteria from DSM-5. Have you ever felt the need to bet more and more money? This is kind of a tolerance question. And lying is one of the criteria. Have you ever had to lie to people important to you about how much you gambled? Yes to either one, and that's a positive screen. The brief biosocial gambling screen, or BBGS, specifies the past 12 months, which is preferable. And it has the withdrawal question, becoming restless, irritable, or anxious. Again, it doesn't come right out and ask if you're a liar. It's worded a bit more gently. Have you ever tried to keep your friends or family from knowing how much you gamble? Slightly gentler language. And bailout. Have you had such financial problems that you had to get help with basic expenses? And if, again, yes to any one of those, and that's a positive screen. Have you, the nods clip and the nods, 2 questionnaires were based on a larger set that were used in the last federally funded prevalence study, which was back in 1999 out of Newark. And folks from Illinois are probably more familiar with that than folks in other areas, out of the National Opinion Research Center out of the University of Chicago. So have you ever tried to stop, cut down, or control your gambling? You know, the loss of control issue, common to addictive behaviors. Have family members, friends, or others, have you lied to them? The lying question. Preoccupation, have you spent a lot of time thinking? And that's one of the diagnostic criteria as well. And this is lasting 2 weeks or longer. So slight differences there. And again, one is a positive screen. And a different set from that larger survey. Again, preoccupation. Escape is another one of the diagnostic criteria. Getting away from uncomfortable, unpleasant feelings or personal problems. And chasing. This includes a chasing question. That's another one of the diagnostic criteria. If you lost money one day, would you go back another to get even? And relationship, the negative consequences criteria. That's also a diagnostic criteria. So any one of those 4, and it's also a positive screen. Now, these are lovely evidence-based screens. They work fantastically in the research. If you use them with a substance use in treatment population, you're going to get about 20 to 50% screening positive using those screens in research studies. In clinical practice, they don't work nearly as well. Studies using actual clinical settings find that you get about 1 at the most 3% responding positively. And when we did our first screening training in Illinois, and we were training people, use this slide bet questionnaire, first ever evidence-based screening tool. You're going to find all these people in your programs, because most of the folks we were training were substance use disorder counselors. And we were so excited. We went back home and we expected we'd get emails that they were finding all these people, and it was crickets. We felt like the Maytag repairman. Nothing was happening. We came back and said, well, how many did you find? None. And of course, we blamed the counselors for not doing it right in all our wisdom. Sorry about that if any of you are still out there. We didn't know that these brief screenings just don't work in real life very well. That doesn't mean you don't use them. And there's some things that you can do that may help. For example, if you just throw those questions in there without providing a definition of gambling, you're going to lower the results. The South Oaks gambling screen does a little better because it has a whole section on how often do you buy lottery tickets, buy scratchers, go to the casino, play cards from, all the different types of gambling, and then people are primed to understand what you're talking about. Many people don't automatically categorize certain common forms of gambling, like buying lottery tickets, as gambling. I don't know what they categorize it as, paying my fair share of taxes. or they don't categorize bingo games. That's just charity. Only consistently people categorize casino, gambling at the casino, or sports betting as gambling. Other things they categorize as recreation, as charity, as socializing, but not as gambling. So we really need to provide that concrete definition with examples. As I alluded to, these questions are the tip of the iceberg questions. They're diagnostic level questions designed to only identify the most severe cases of problematic gambling. So, we're raising the bar pretty high here. And as I mentioned, the words seem kind of harsh. The first question you ask somebody about gambling is, are you a liar? Who's going to say yes to that? When I go to my primary care doc, the first question she asks me about drinking isn't, how often do you come home falling down drunk? She asked me a much more benign question, like, you ever have a little glass of wine with dinner? Much easier to say yes to that than, how often are you drunk? So a lot of issues to be considered. And also, I've had many lovely counselors tell me, well, what I used to say, these would be the last two questions after, an hour and a half of intake. And I must admit, I'd say, you don't have a gambling problem, do you? Wink, wink, nod, nod. Let's say no, and we can both get out of here. And they didn't even realize they were giving them the preferred answer that they wanted to hear. And for a lot of reasons, that's not why they're here in the first place. This person doesn't look like they have a gambling problem, whatever. So how we ask may be as important as what we ask. So the recommendation and the solution is to add in that brief definition with specific examples. The following questions are about gambling. Is it okay if I ask you these questions? And by gambling, what we mean is when you bet or risk money or something of value on an event whose outcome is uncertain. For example, buying lottery tickets or scratch-offs, gambling at a casino, playing bingo, shooting dice, betting on sports, playing Keno, risky investments in the stock market. We can use those forms of gambling that are most common in our jurisdiction. And then add a gentler leading question. And the one question used in that very large national study that we talked about on co-occurring disorders used, have you gambled at least 5 times in the past year? And if you said yes to that, that was that at-risk category associated with higher levels of medical problems. So it seems really low to me. I mean, I fit that because that's when Powerball or Mega Millions is over 200 million and I buy my one ticket. Another way is to ask, do you gamble weekly, daily, more than once a month? And some research suggests that once a month or more is above average, and you might want to use that as a cutoff to lead into and create a risk category. And this is Illinois' own Seth Eisenberg, Disordered Gambling, SBIRT Pre-Screen and Screen, and collaborated with Elizabeth Hartney on that. And you can see they put the definition, the gateway question. If yes, you go on to the first 3. And these are the brief biosocial gambling screen questions. And those are my preference for the first screen to use because of the slightly more gentle language that's used. And then in this screen, if there's a yes to that, you automatically go on to all the other diagnostic level questions. And they're stepped response based on risk level, is the high risk group is 7 or more of those questions. Now, I might make that lower because we found that even answering 1 or 2 questions creates risks in terms of higher levels of depression, anxiety, and medical problems. But, that's to be played around with. Moderate risk is defined as between 1 and 6, or multiple risk factors in an unsupported environment, and low risk, and what you would provide for those individuals. Oops, getting ahead of myself. So one example that I'm sure you'll be becoming more familiar with over the next several months. And similarly, for our work in Maryland that we've done, we use the brief biosocial gambling screen. We have our definition question, and we use the same gateway question before going into the brief biosocial gambling screen items. We define low risk, very low. Somebody answers no to everything. No, I haven't gambled 5 times in the last year. Okay. High risk, yes to yes, I've gambled, and yes to one of the other questions. And so now, what are our brief interventions? And we were doing our research in a primary care clinic. So with busy clinicians who focused on medical issues and don't have a lot of time, and certainly aren't going to become problem gambling counselors or experts in this, unique field of interest. So we had to design appropriate interventions that could be easily implemented by folks who are not problem gambling experts in a very busy clinic. And we want it to go no longer than 3 to 5 minutes. And we want these to be motivating and encouraging, as well as providing some information. And motivational interviewing as a strategy is really key to expert interventions, being empathetic, developing discrepancy between what a person wants in their life, the outcomes they want, and the activities they may be engaged in, not getting into an argument, rolling with any resistance, not pouncing, and supporting the person's ability to do what they can do and to be autonomous, to come to their own decisions. So we raise the subject and then provide some feedback, maybe open-ended questions and affirmations. So somebody answers the screening questions. I appreciate, validate. You're answering those gambling questions. I'd like to go over your answers and give you some feedback. Asking permission. How does that sound to you? And remember, what we're talking about is confidential. If it is, or let them know who it's going to be shared with. Okay. And be sure to listen to what the person has to say reflectively, and let them give you as much information as they want. Then again, affirming, I appreciate your honesty. That says a great deal about your commitment to look at any factors that might be affecting your health and well-being. Let me make sure I understand what you said. You said you buy lottery tickets every day, but you don't think that you're spending more than you can afford. Is that accurate? Whatever that might be. Validate and affirm. Ask a good time for any other concerns. This is a good time. Any other concerns you've had about your gambling or the gambling of somebody you care about that may be affecting your well-being or your health. And these are the interventions that we came up with. So for those low risk, folks in our study, the ones who didn't even gamble 5 times a year or more, would it be okay if I gave you some information in case you know anybody who has a problem? And this is focused on what are the guidelines for responsible gambling. And our research assistants came up with this, an acronym, SLOTS: set limits on time and spending and stick to it. And then with our helpline number in case somebody has more questions. For medium risk, somebody who says yes to gambling 5 times a year or more, but doesn't say yes to any of the screening questions, there's a brochure. And notice, it's not the problem gambling brochure. This is gambling in your health. So it gives some more information. It can be fun, but for some it can be out of control and result in a range of problems. And on the inside, some concrete examples of what low risk looks like. I only buy lottery tickets a few times a year. Medium risk, I go to the casino once a month. I can afford to spend, but sometimes a bit more, so there's some risk factors creeping in. I get kind of mad when I miss going to the casino. High risk, I bet on sports all the time, love the way I can bet on almost every play, and you can see how we're getting riskier. And we ran these all through a variety of focus groups, and the focus groups love the checkoff boxes. So some warning sign checkoff boxes just for your information. And you might have, as a provider, a brief conversation and point out some of these things. Then for high risk, assessing the readiness to change as well as enhancing motivation. We bring in our handy dandy motivational interviewing tool of readiness rulers. And this was our high risk handout, a bit more of a worksheet. And again, it's not the problem gambling worksheet. It's would you like a handout on understanding more about your gambling? And again, it can be fun, but it can come along with some problems. A bit of information, and then where are you in terms of, your willingness to think about changing any gambling habits on this scale of 1 to 10. How ready are you? If it's a 3, well, you're 30% ready to think about changing your gambling behaviors. Let's look at that a bit more. What would your change plan be? How many days a week or a month do you think it would be best for you to gamble? How much money per week or per month do you think it's safe and healthy and non-stressful for you to spend? Is there anything you'd like to do in terms of taking any actions? Would you like to talk to the helpline folks in the next month or in the next few weeks? Would you like to talk to a counselor? I can give you that number. Would you like a referral right now? Would you like a list of self-help meetings that you might want to check out? And if they want to do any of those, or would you just like to check in with me in your next appointment and see how things are going? And you write down what the follow-up is. And the next time they come in, you can check that out, because this document, or you will document it in the medical record, will be there, and you'll follow up on that. How's it going? And I asked you those gambling questions. What have you noticed since your last visit? Whatever that might be. And a lot of tips for successful expert interventions using motivational interviewing, being non-judgmental. You don't judge, be aware of any preconceptions about gambling and gambling disorder you have, from it's no big deal, everybody gambles, why am I even bothering wasting my time asking these questions? We have better things to focus on, as a preconception and a bias, to gambling always causes problems. These folks are already dealing with addictions. Why are they adding another one? They should just stop. So you can have a whole range of in-between preconceptions. Always asking permission to talk about a topic, to give feedback, to give more information, get buy-in. This is a collaborative process with our clients. Validate anything you can that's incremental in the right direction. The willingness to think about it, their honesty in talking about it, to ask questions, to look for more awareness. Don't use labels. Use the language the client does. Don't demand that they label themselves something they're not ready to label. How do you talk about? What words do they use for their gambling activities? I know many clinicians who say, I don't even say the word gambling. Do you play the lottery? Do you play these kind of games? Do you go to the casino? If I can avoid the word gambling altogether, I get better responses. Assure your client that I'm asking because we found that these kind of activities may be related to how successful they are in reaching their healthcare or recovery goals. As much as you can, assure confidentiality and notice any indication of resistance or discomfort and acknowledge that. You seem to be getting annoyed about these questions. Anything you want to ask me about. Yeah, why are we doing this? That's great that you ask. I'm glad you're aware. And then you can provide some education. Important if we're considering implementing a gambling expert to plan for that. Don't just throw it at clinicians. Don't just throw it at staff. Don't just throw it at clients. We need to develop protocols, policies, and procedures about how we can best do that and how it can best fit into our existing practices. It's not a one size fits all. We can tweak this to fit the things you're already doing. And we should give time to this planning phase to get feedback and cooperation from all levels of clinical, non-clinical, administrative staff, and maybe even some client focus groups. Most helpful to do a training of all staff, at least a baseline training, so all staff, clerical, clinical, business office, financial office, know what we're planning and doing and that we're going to be bringing up this new topic to get people to buy in and become familiar and more aware. Initial and ongoing training of those who are going to be more specifically involved in the administrative so they feel comfortable and competent doing this. Deciding who will be screened. Will we do everybody? Will we identify a high risk set? If we're doing it in criminal justice settings, as they did in the Amherst court, identifying financial crimes as the high risk group where they would do the screening, and other crimes not so much. When will it be conducted? At intake, at admission, during a biopsychosocial, or in college settings during orientation, which clinics, or will it be done later once a relationship is established with a clinician? How often? We don't just do this one and done. Every time I come in for my physical, I get screened on the drinking questions and other questions. Every appointment, every time we update our treatment planning, and what are the roles? Who does what? I may ask the screening questions as the intake person, but then the feedback may be passed off to a counselor or a social worker. So there are a lot of ways that this can be done. As we talked about what screening interventions, what information and informational materials will you use? How will this be documented? What's the follow-up? And what are your referral resources? Is it just the helpline as a one-stop shopping? Do you have specific providers within your agency who are specialists that you can refer to? and creating that list. And then how are we going to evaluate this once we do implement it? So, wow, a really quick tour through the world of GBIRT. These are all the references that the specifics we talked about were based on. Lots of references, so I'm not just making this stuff up. Back 20 some years ago when we were first doing this, often we made stuff up or certainly based it on our anecdotal clinical experience because there was no research. We're in much better shape now. We have some guideposts to help us do things, with a bit more solid informational grounding in that. So I wanted to leave time for questions, which I often don't. So sorry if I was talking fast. Let me check in on some questions here. And thank you all so much for your attention.
Dr. Rugel, you do have some questions. If you'd like me to read those to you, that would be okay.
That would be lovely.
Okay, so your first question that we had is with the amount of money, I could probably answer this one, but with the amount of money that is brought in, do we believe that the governments, federal and state, will ever admit the issue and fund support for treatment?
Well, Kelly's probably better, but fortunately, Illinois is providing funding for treatment. The feds, that's an uphill battle. It's being fought at the national level, but who knows? So it's a state by state situation. Anything else you want to add to that, Kelly?
No, I just would say the same. I mean, we have been providing gambling treatment for over 20 years now, and we are seeing it continue to increase. So definitely in the state of Illinois, we are working with our government to provide those services for individuals and their families who need the services. So if you're looking for services or looking for where those services are provided, you can visit weknowthefeeling.org, and we have a list of providers there. So I don't want to take from your times for questions. We have two more, Dr. Rugel. The second question is this an age-specific assessment, or do you have a different tool for adolescents?
Yeah, there are different tools. Unfortunately, none quite so brief. But I can certainly pass those on, and those can be available. One is based on the South Oaks gambling screen, so it's quite lengthy. And the other is based on substance use screens and has certainly more than 9 questions, I believe, and it's a little bit cumbersome to score. So the resources for adolescents aren't quite so good.
Great. Okay, Dr. Rugel, a couple more questions have come in. If you have a moment, we still have just a couple of minutes, but what do you think, or what do you do if the client says no when you ask permission to ask questions about gambling?
Yeah, I would say, well, thank you for being so honest. I appreciate that. Maybe we can revisit these in the future and just move on. We somehow feel this really intense responsibility, to make clients answer every question we throw at them. I think we have to be more willing to say that's okay if you're not ready to talk about that at this point. I'll keep checking back and provide some education.
So Dr. Rugel,
reinforce that we're asking these not to, dig into your business, but because, our best research suggests that there may be, some correlations between gambling activities and your substance use disorder, your mental health status. And we just want people to have as much information as they can in order to make the best decisions for yourself. And it's not about not gambling, it's about gambling wisely. So I would provide some education and then move on.
Excellent, Dr. Rugel. You make services for gambling, for those who need the services, so welcoming. So we really appreciate all that you've shared with us today. I'm going to ask one more question that came through our chat box, and from there we'll stop there after this one. But what is the recovery rate of gamblers who have substance abuse or substance use problems? What do you treat first, substance or gambling, or both?
Yeah, I don't see how you don't just treat the whole person, you know, so you may focus on what the client thinks is most important. Now, certainly, I mean, my rules are, number one, keep the client alive. So, you know, if they're not alive, there's not much you can do. So whatever might be most lethal, you need to address that. But if the client isn't willing to address that thing, you're not going to get very far. So they go hand in hand. And even if I'm addressing the substance use first, I'm going to be connecting the gambling to that and to what goals the person has. Yeah, and I've had lots of clients who are real clear that the next drink may kill me. They don't recognize the impact of the gambling. So you focus on this, the next drink, but say, gee, you know, the last time you relapsed, it was after you had a big win at the casino. You know, if you continue to go to the casino, how are we going to protect you from celebrating by drinking? You know, or, you know, do you need to not go to the casino? What do you think? And to just do that connecting of the dots, realizing I can't make anybody do something they're not ready to do. But I can bring information more into their awareness about what they really do want to accomplish. So it's that kind of a balancing act.
Dr. Rugel, you have been wonderful as always today with the information you've shared with us. We thank you from the state of Illinois on behalf of all of our staff and our providers. We thank you for what you've shared today. So at this point, we are going to actually phase into a break, a 10-minute break. And then we'll come back for our next sessions. If you are going to a different session, please click to the next session you will attend. Again, Dr. Rugel, I just can't thank you enough for what you've shared with us today and over the years.
Well, thank you so much. And certainly my slides will be yours to do whatever you want to with. So
thank you. We have lots of requests for your slides. So
very much.
And this isn't the last time we'll see Dr. Rugel.
Bye-bye.
Bye-bye. Thank you, Dr. Rugel.